now. It's going to go. Just take. Hey, Dr. Palter, how are you doing?
Great to see you, Mark. So glad to be here.
Well, I'll tell you, we have quite a treat tonight. Tonight we're joined by Stephen Palter here, Dr. Stephen Palter, founder and medical director of Gold Coast IVF, which is an internationally recognized fertility expert. This guy is a true innovator when it comes to reproductive medicine. He's always the one giving all the evidence every time I'm on in REI forums. He's pioneering advanced medical treatments. He has a special method called the Palter method and the PCOS to pregnancy protocol. His work has helped thousands, truly. I met him a long time ago when we started getting into like TikTok. And one of the things that was interesting is a lot of people were just giving information very superficial. And what I really liked about Dr. Palter was he really, kind of like myself, I feel like, didn't just sit there and go, oh, go through IVF. He always wanted to treat the cause. And treating the cause is so important because I get people come in, I tell them, yeah, IVF is going to work. But if you don't know what you're treating and it doesn't work, you're going to sit there and go, why didn't we just look at this? We could have figured out with something else. And so this is one thing that he does really well. And I have a love for PCOS. He has a love for PCOS. And, I think if you have PCOS, you are in for a treat. I feel like I know a lot about PCOS. I honestly think he's going to run circles around me. So I'm excited to talk to him tonight and for us to go over things. So, Dr. Palter, if you want to introduce yourself at all, anything that add on to that and kind of a little bit more about yourself.
Yeah, thank you so much. I'm so excited to be here. I don't know if you heard the little alarm running. It was our simulcast. It was one of the softwares was saying we can't go live on that platform. So I'm love what you're doing here. I love how many people you help, and it's true. We do things very similar in a lot of ways. We met here online, educating people. When I first started, I had got accepted to medical school when I was in high school. I thought I was going to become an endocrinologist, and I wanted to treat diseases that we could fix problems. And I love new technology. And so I saw infertility and I said, this is the answer to all of my lifelong dreams. And I got involved very early on and said, that's what I'm going to do. I completed my medical education, and then I did my fellowship at Yale and became the clinical chief of infertility at Yale University, stayed on as a faculty member. And for years, I was running physician education. We're doing large, thousands of doctors, teaching them sort of cutting edge things. And then all of a sudden, in the last years, I would have my patients would come in and they would be doing things that made no sense. And I'd be like, we gave you instructions, and why are you doing this other thing? And they tell me that they watched someone on Instagram or someone on TikTok, and these influencer told them what to do. And I had some patients that were influencers, and they said, why don't you teach patients? And I said, I can't do it. Like, I'm not cute. I'm not blonde. I don't even have hair. I can't dance. Like, no. And they're like, that's not what it is. Like, you can actually teach people. And so I said, great. And I started educating people because as a physician, if you treat problems, you hear the same thing over and over from patients. I did this and the doctor didn't do that. Or I tried this and it didn't work. And you see patterns of where people get in trouble. So I started teaching, if you have this problem, do this. And it immediately took off, and got to the point where I have over 600,000 followers now and over 650 million views of my video streams, and my medical problem series has like 70 million views. And it's funny, there's some people that want to go on social media because it feeds their ego. They're a status influencer. And some people want to get customers and they're a marketing influencer. And I like to say that I'm a solution influencer. I like to solve people's problems. And I never imagined that I would have thousands of people write to me saying, I saw a 60-minute video about my problem and went to my doctor and got pregnant. And that's, how you and I got together, because you were teaching as well and you were explaining problems, and that's what we do.
Yeah, I remember when we first started, like I said, there was a lot of superficial information out there, but I started showing things in the lab. You started showing needles. I remember one of my favorite ones you did was the largest, I think it was the largest needle in medicine, which was
Yeah, so
the retrieval
infertility,
needle.
we have the longest needle
Yeah,
in all of medicine, and we have the smallest one, which is the one that
exactly.
we inject a sperm into an egg for
Exactly.
egg.
One of the things I'm sure you deal with this all the time is when I'll get patients in and I'll have my consult with them, and the thing I always hear is, wow, my doctor never spent this long. I think it was like 5 minutes or something. And I said to them, well, I have to get the information to know, what to do here. And so I think that's one thing that's going to be great when we talk tonight about PCOS is this idea of what is it really behind PCOS. I know you and I had this conversation the other day where I was telling you, I look at PCOS more as metabolic disease. And it just happens to be they have ovaries. And so we see these polycystic ovaries on some of them. But like I said, I'd love to, kind of hear your view on PCOS and kind of, we educate people tonight. And the
Yeah,
people
but
who do want to come ask questions, they come on the show. And like I said, they can come on and ask your questions live. So
well, before get to that, when you talk about that, you spend time talking to patients. So, that's where we started decades ago. We were getting a history, figuring out the root cause and seeing what's wrong. And unfortunately, in all of medicine now, as things have become very corporate and very procedurally oriented, and some places have benchmarks not of how well they treat their patient, but of how many patients they treat. I always say, if no one's asking you what's wrong, and if something doesn't work, they say, bad luck, stuff happens, and they do the same thing again. And you ask, why am I doing this treatment? They say, because that's the protocol. Those are the 3 red flags, like no diagnosis, no troubleshooting and asking what went wrong. There's always a reason. We just may not figure it out.
yeah,
And
correct.
and the protocol is not the answer. Like the doctor could say, here's why I follow it. That's intelligent. But if you're just blindly doing it, that's where in medicine people get in trouble.
Do you ever find, and this is a side question here, I feel like sometimes because we are so specific to each patient, so customized, it actually hurts a little bit. What I mean by that is this. They'll go to other clinics, they're like, oh, everything's so smooth. I call up, they know everything. I said, no, they don't. They're just doing the same thing with everyone. That's how they know what to do. They say, come on this day for your IUI. They don't change it for anyone. They tell everyone to start at this time. And so I tell them to go like, but your clinic, I have to wait back for they get back to me. I go, that's because it's customized. They come to me, I have to give them an answer, and then they get back to you. I feel like sometimes our clinics get a little bit punished for that in some ways because it does look very fine-tuned when you always have the answer right at the first second when they call. But in reality, it's because they're just doing the same thing on everyone.
Right. I've said to patients, if I just wanted to lie to you and give you sugar-coated lies, I could hold your hand and say, here's what you need to do, and we would have been done in 5 minutes. And instead, it's 45 minutes later, and I'm explaining to you what we know and what we don't know, and let's pick together the right path for you. But if you make it where there's, everything's black and white and you don't analyze it, it's really fast and it sounds good. The same thing happens online. Some guru will try and sell you a solution. Take Wonder Supplement X and everyone gets pregnant because it cures everything. Well, that's not honest, and it sounds very good, whereas someone else says, in this case, this works, and in the other case, the other works. That's real medicine.
Yeah. Another thing is, and I find would be a really cool topic for us to talk about. We had this conversation too the other day, was PCOS itself doesn't make a lot of money. When I say that, obviously, when I say a lot of money, we're not all trying to own the odds, but then, we still have to pay bills. We have to pay our nurses. And it's one of those areas that I feel like sometimes it does get pushed to the side because they come in, they're like, oh, just put them through IVF. And as you and I know, shoving someone in IVF usually does not the outcome is not good because of that inflammation and insulin resistance in their body before addressing it. And so I love to hear, this kind of idea, like what can we do as a society in fertility to make it where PCOS is treated better, like I said, that it's something that maybe is reimbursed better so we can spend more time on it. Because I used to before we got busy, and now I have to prioritize what I can do. I only have so much time.
Well, this is sort of what's happened with medicine in America overall and infertility a lot, especially because these things that are complex and lifelong diseases take a lot of time, and coaching someone through lifestyle changes is very labor intensive and doesn't get paid at all. And that was sort of the genesis of my PCOS to pregnancy program. Was so for years I was working with people with PCOS, and we knew that there was a metabolic component and a lifestyle component, a diet, exercise, inflammation. But our field was treating it with IVF. So I was doing this to get people ready, and we saw people getting pregnant while they were just prepping to do their IVF. Or I would have a patient that saw me online that was coming from another state, failed IVF, and I would be doing the prep and they would get pregnant. Or we would do a cycle and they'd have better results. And I kept thinking, wow, what if I could just do the prep part for everyone? And I said, well, I couldn't possibly do that. It doesn't work, and there's not enough people. And what happened was, when I got 1 million views a day online, suddenly there were thousands and thousands of people saying, could you just help me get healthier? And I built out a system that's completely online and virtual that does that. So people like you and patients that are working on their own can have that hours and hours and hours of guidance and lifestyle benefit that the medical system doesn't reimburse.
Yeah. Oh, most people just tell them lose some weight. That's usually
right.
What they're told.
Yeah. So, you were talking about the root cause of PCOS and calling it, a metabolic problem. So I call it diabetes of the ovary, because the metabolic, so PCOS has a lot of causes. There's hormonal irregularities that women have. There's elevated male hormones. There's problems in the pituitary and the hypothalamus. There's genetic predispositions. But a huge component of it is insulin resistance and the metabolic underpinnings. And so PCOS now is the #1 hormonal disorder of reproductive women, and it is the #1 cause of infertility in the United States. So this is huge. It's like infertility went from 1 in 10 women to 1 in 6. PCOS went from 5% of the population to 15%. So you're talking millions and millions of women. And this metabolic component is at the core of it.
Absolutely. One of the questions that came up, and I think would be a good one now, I really want to get in learning a little bit about the Palter method. I think it would be great for us to talk about. Before we get to that, I want to help people understand a little bit more about PCOS. But, talking about that metabolic, what's your main treatment for treating the metabolic, other than, obviously there's some medications out there, there's diet, there's stuff like that.
So let me say for 1 second first, let me just touch upon what PCOS is. So PCOS is a hormonal disorder that affects almost every organ system. It's the most common reproductive disorder of hormonal disorder of women that I said. It affects you at every stage of your life. And the hallmarks to make the diagnosis is you have to have 2 of 3 conditions. You either have to have polycystic looking ovaries, and I hate the word cyst. They're not cysts. They're developing eggs that stop developing. So there's tons and tons of eggs that start to develop and stop developing. And when they do so, they start making excess male hormones. So that's the first hallmark, are all these eggs. The second one is elevated male hormones. And the third one is irregularity or absent cycles. And so that's hirsutism, extra hair. And so that's one of the manifestations of the elevated male hormones. Previously, it was said that, so many of these women are obese. They don't have to be. 80% are obese, but 20% are thin. And they suffer in that when they're young, they have irregular cycles. They have facial hair and acne. Many are obese. Period doesn't come for months, and then they hemorrhage when all of a sudden it comes, they bleed. Then when they get older, they have infertility, irregular cycles, and then they'll have 3 times if they have infertility, #1 cause of infertility. If they get pregnant, they have 3 times the risk of diabetes in pregnancy. A third of them will develop diabetes by age 40. They develop liver disease. They have depression and anxiety as a result of the hormonal abnormalities, and they have increased risks of Alzheimer's, cognitive dysfunction, cancer of the uterus, heart disease, and elevated lipids. So it hits every part of this woman's body at every stage of her life, from adolescence to menopause. And so that's what it is. And when you talk about the metabolic, how do we treat the metabolic portion? So if you think about all of disease in America that's getting worse, our genetics hasn't changed. I got into an argument with someone at a conference I was presenting, and he said, well, it's all genetics. And I said, well, how come the incidence has gone up 3 times? It's triple what it was. Has our genetics changed? No, what's changed is our environment and our lifestyle and obesity. Now, that doesn't mean the woman's to blame. You gain weight when you have PCOS,
Yeah.
but it's a hereditary throwback to caveman times where people were starving. So certain genes allowed you to store fuel. And now when we're in a time of horrible food abundance with processed foods and carbs and fats that were never in nature, and there's so much obesity, heart disease goes up, diabetes goes up, and PCOS goes up. So what happens is people say, oh, when I see a patient, I can always say, I can know if your last doctor was skinny, because what they said to you was, well, eat less, move more, and lose 5 to 15% of your body weight, and just come back when you've done that. And they're like, yeah, okay, it took me 30 years to get here. You think I haven't tried to do those things? That's like telling a diabetic, just stop taking insulin and get skinny. It doesn't work. So what we did was I met Dr. Atkins, when I was a student, and I learned what he was doing with carbohydrate restriction. And then I learned years later, and I tried to apply that when I was at Yale. I wanted to use those therapies for PCOS, and Evan said, my God, you can't do this. You can't use diet. You got to put them on Clomid. And then lately there's been people doing literal diabetes reversal. They're taking people off insulin, curing diabetes that was never thought to be curable by doing lifestyle interventions, by changing their diet. Now, everyone online says, oh, I tried low carb, I tried keto. It's got to be modified for PCOS for the hormonal output. And so we have a system where we go through the way, we don't call it a diet or exercise. We change the way you eat, where you're not hungry and you don't have to lose weight. You don't have to lose weight. You just have to change your insulin metabolism and the hormones correct. And so we guide people through that, but we have coaches and support that every step of the way, where you don't know why you're not working, we guide them to success. And at the same time, we're doing blood measurements and glucose measurements, and we do CGM monitors where we measure their glucose. So instead of it being 6 to 12 months, we have people ovulating within 1 to 3 months that never did before.
Yeah, it's interesting what you were saying about the genetics. And I think, like you're saying, I think it was more of a simplification. There's some genetics here. I mean, there's no question about that. Just like we see type 2 diabetes have genetics that, could be a predisposition. But your point is right, is the reason it's worse now is because we do have higher calories. Our diets have changed considerably. So as I told you, I love PCOS. When you go back, it's really interesting.
No, Mark, the anecdote I'll give you is your genetics loads the gun and the American diet pulls the trigger.
Exactly. And what happened is, a lot of people don't realize this, that you can actually see where this happened in time. If you go back to the food pyramid, years and years ago on the food pyramid, there was this big push to push carbohydrates and reduce fats. And so when they came out the food pyramid, all these companies started pushing all these carbs because they didn't talk about the good carbs versus the simplex carbs. And so all these foods were pushed with all this corn syrup, things like that. And this has just created
where they came from. Do you know where the number one source of food scientists working for like Nestle and all these, where they got trained?
No.
So they were in the tobacco industry. And when all the legislation came to end tobacco, hordes of these scientists moved to food, and they made food addictive. Yep. So if you look at your grandma and great grandma's time, you had meat and vegetables and you ate a couple times a day. Yep. And if you had a portion, it was this big. So the idea was, how can you get a massive amount of volume for a tiny bit of money that has an endless shelf life, and you can't eat just one of them? When you combine fat, salt, and carbs, it lights up the brain. Same signals that smoking and drugs do. It is addictive. So if you look at women with PCOS, one of the reasons why it's different than diabetes, I tell these diabetes reversal people, it's a 50-year-old man with a pot belly is different than a 30-year-old woman. They have a lot of binge eating. They have a lot of food addiction. There's a lot of emotional eating. There's a lot of comfort eating. And they also restrict their calories, and they eat sometimes nothing, and they're still gaining weight because it's the food itself is toxic.
Yeah. It's funny because I liked how earlier you defined that I'm not skinny, because I don't tell patients to do that. So I must have been one of the not skinny doctors. But one of the reasons I think it's important, like you said, to hit the core. I focus on reducing that insulin through either caloric restriction we talked about, because not just any diet will work. You can't just do a low fat diet. As you said, that low carb has to be low calorie. But the other thing is exercise has been actually proven to have less benefit than diet. That's something that I think a lot of people don't realize.
Oh yeah, again, another dogma that I follow is you can't outrun a bad diet. So
correct.
When people start the program I have, it's PCOS to pregnancy protocol. What we say is you don't have to lose weight and you don't have to run till you're starving, because if the core is what you're eating. So first, reduce the insulin, reduce the carbohydrates, the hormones start to normalize. Once you stop eating carbs, so what do people complain? I was starving in the middle of the day. I just needed, and then I ate something. I had a bar and a snack, and I crashed. So when we put a 24-hour glucose monitor on these people, their blood sugar shoots up to 250, and then it plummets. And when it plummets, you get hungry. So you think you're hungry, but you're really not. It's the effect of this stuff. And you could exercise, running, and weightlifting improves insulin resistance, but that's like the 10%, and the 90% is what's going in.
Yeah, I mean, there's I sometimes use this analogy. I explain to people that if you eat my favorite bag of Cool Ranch Doritos, which is it ends up being about 3,600 calories, so a pound you would gain from eating a whole bag of that. If you are a female and you run a marathon, an entire marathon, you lose about 3,600 calories you burn off. And it kind of shows you that most people can't run a marathon, but pretty much anyone can eat a whole bag of Doritos. And so it just shows you why one is so much harder than the other one. And that's why it's easier to cut back with the diet than it is trying to run another marathon. And for women, the big thing is that their muscle mass is so much smaller. Like a guy, I tell guys all the time, you have no excuse to be overweight as a guy. I said, you have the ability to jump on a treadmill, and in a few amount of hours, you can already start burning off tons and tons of calories. But our muscle mass is so much greater than females. And so it does limit them. There's actually several studies out there that have shown that women, if they have a BMI over 25, they will not lose weight working out for an hour a day with moderate intense exercise 5 days a week. That's how significant it is to affect the diet more than the exercise.
Right, but you don't have to starve yourself. So like the
Correct.
idea that eat 500 calories and eat like 10 bowls of lettuce and be starving, your metabolism slows. It's a stress on the body. Cortisol goes up, and they do even worse. So what we do is, a lot of people say, "Oh, I tried keto and it didn't work." Keto is a different goal. It's
hard.
All fat, no carbs. It's not what's perfect for reproduction. What we focus on is we do ultra high protein, very low carbs, and fat doesn't matter. So we're tanking insulin, but we're giving the protein to support metabolism. And that's what triggers the hormonal reset and the ovulation.
Yeah, absolutely. One thing that I find really interesting is I get a lot of patients come in and go, well, I've been diagnosed with PCOS. And one of the things I tell them all the time, I go, well, let me first figure out if you have PCOS, because I said, if your doctor just guesses, they're going to be right 90% of the time if you have irregular cycles, because 90% of the time it's going to be PCOS. And that happens a lot. I feel a lot of people just throw that diagnosis out and not look at. I'm sure you, just like myself, have had people who thought they had PCOS and diagnosed other conditions. Right. I diagnosed with a cancer one time. It was a granulosa cell tumor they had, and it was producing so much estrogen that it converted over to testosterone, and she developed similar symptoms to PCOS. And so I think it's really important for people to understand that, like, you really want to have someone diagnose it who knows what they're doing. And I think that's going to be a reproductive doctor, really, or endocrinologist.
Yeah, one of the cool things that we did in our program was we developed a risk assessment where we go through, a couple dozen questions of people, of their history, self-reporting symptoms, and we can get to like a 90% accuracy of a diagnosis. So most of these things that women can make today. If you need, we said you need three things. So two of three things. One, elevated male hormone. So if you have severe acne or coarse facial hair or chest hair, you can diagnose that yourself. The second one, irregular cycles or absent ovulation, you can diagnose that yourself. And now you couldn't do the ultrasound, but now there's a blood test called AMH that and a very elevated AMH allows you to make the diagnosis. So three of the three, a woman could do 90% on her own, probably better than a lot of doctors that aren't looking for those.
Yep. We actually have a question here. I was going to pull it up here, and hopefully Juliana will come on the show, but she was asking, why does managing my PCOS feel like a full-time job? And I mean, my first answer would be because it is a full-time job, but I would love maybe your method, kind of jump in and explain like how yours is a little bit different.
Yeah. So if you could put up, part of the difficulty is there's so much conflicting information and it's so hard to know what to do. There's 20 supplements that have been shown to help PCOS in some degree. So do I take berberine and inositol and curcumin, and how do I do all those? And then I've got to do keto, but now I've got to do low fat, but those are different. And then now I've got to be on inositol, and how much exercise. So you have 1,000 things that affect it, but you don't have a system to guide you of what is the simple thing that will get you 80% of the results. And you don't have someone guiding you. Like I had a patient saying, oh, I'm eating low carb. And we put a glucose monitor on her and we see her spiking at 2 times a day. She was eating gummy vitamins that were all sugar that she didn't know. And she was having oatmeal and mangoes for breakfast because they were heart healthy, full of sugar. Yeah. So I'll tell you, if you put up, I don't know if you have we'll talk about how to make it easy. Do you have the thing Inspire, the graphic Inspire?
Yeah, let me grab that.
I have just some screenshots of people in our program, and she talks about this. This woman says, I'm sharing this because you can do it. She got pregnant in the first month after years and years of infertility. After 8 years of heartache, she got pregnant in like 6 weeks on our program. Go to the second one, number 2, and she'll talk about what this question is. Inspire 2. She says, I struggled for infertility for 8 years. I never had a positive test. I've been doing IVF for 3 years. The transfers didn't work. And I couldn't bring myself to spend money on another thing that wasn't guaranteed to work. But I told myself I had to try. The science makes sense. Why would an embryo stick if I had crazy blood sugar spikes and tons of hidden inflammation? I have to take care of myself first. But that seems so complicated. That's like, just go lose weight. How do you do it? So you could put that down now, Mark. And so what we do is we, in the first week, focus on the diet. It's basically, I made it like a TikTok or Instagram course. It's me speaking to you like this for 3 to 5 minutes a day and saying, here's what you need to do today. We have a tracker app and we can do blood sugar monitors, and what's working and what's not. So someone just says, don't eat carbs, and then you do a blood test every 3 months. How do you know if it worked? If you're wearing a glucose monitor and it spikes after your meal, Then you're stressed out and you don't know what to eat and you binge on something. Well, we've got a coach that will speak to you and say, here's how you're going into this situation. Here's how to prepare for it. I don't know what to eat here. You've got a coach to help you through the process. So it's like 20 years of all the confusion, solving those problems and having a resource to say, when you don't know what to do, instead of going online and watching 40 videos, we'll guide you to do it. So what we do is we simplify it. Instead of 100 things, you've got one thing to do a day, and that gets you to success.
I know when I did this, I talked about, I used to have a PCOS clinic, and all I did was they would come in for, we check the weight, we would check glucose, insulin levels. I would go over their diet. They would tell me what they eat. I said, listen, here's some adjustments you can make on. And exactly. When I held their hand, they did very well. I mean, I had patients lose weight, patients get pregnant naturally. They lost a lot of the symptoms that they dealt with. But as you mentioned, trying to make this simpler, because again, that's expensive to have to see a doctor every few weeks, you know?
That's why we built this virtually, you know, for the price of a consult, like less than seeing a doctor, like the initial consult, that'll pay for the whole program.
It's amazing. When you look at your program and you know, you kind of follow up on it, I mean, what type of statistics are you finding with your program that, you know, like half the people are you getting to where they want, like just general?
Yeah, I mean, so what's new is at first it was just being done with people who were already doing IUI and IVF.
Yeah.
So, and they were multiple failed people who were coming here as part of treatment. So what's brand new is doing this. What's new is doing this completely separate. So our results are pretty much matching. There's a much larger literature of using these interventions where about at least half of people will ovulate on their own, up to, you know, 50 to 70% will ovulate on their own. And if they don't have other infertility problems like blocked tubes or male factor, a majority of them will get pregnant as well. But what we see that's different is instead of it taking 6 and 12 months, we see the results in 1 to 3 months.
Yeah. You know, we're fortunate enough, Dr. Salem has got out of traffic now, so he's going to join us at this point.
Hey guys,
Salem, how are you doing?
It's great to be here. I'm so sorry that I ran behind a little bit, but definitely very, very happy to be here today. And I didn't mean to interrupt the conversation. I know, Dr. Palter, your fantastic viewpoint on everything here is what really counts. So I'm gonna sit back and enjoy what you have to say here as well.
Well, I'll give you, I want you to share, if you could share. I love what some of the women say. Do you have this woman was like an influencer online who went through the program. Do you have the one that says oatmeal?
Yes.
So this was a woman who had multiple failed. This was a video she put up.
To get pregnant, we spent so much time and money in fertility clinics doing tests and IUIs and rounds of IVF and embryo transfers, none of which worked. I finally got so fed up. I changed doctors, had a consult with a doctor up in New York. He gave me some advice on some lifestyle changes he thought I should make, and I got pregnant the first month I tried them. Completely on my own, unassisted, no fertility drugs, just me, myself, and I, and my husband. What we were seeing was evidence of the metabolic aspect of PCOS. I was carrying a lot.
So she goes on like, oh, I had all these features of PCOS that no one ever knew what I had. And she was doing IVF and not getting any blastocysts. Then when she got blast, none of them were euploid. And then she spontaneously gets pregnant on her own. And so what's shocking is how quickly the body responds. And I spoke last week with some of the people using the same protocols, the same concepts for diabetes reversal, and that's how they get people off of insulin as well. The difficulty is figuring out, what do I do day by day? And that's what we try to make simple. Oh, I see you've got the link here. So if anyone wants to sign up, it's PCOSbaby.com, and we have a special Dr. Amol's discount. Amol's 20 we'll give you is a discount for 20% off, and it's cheaper than the initial visit just to come us. Our goal is really to see, can we get, can 100,000 people get pregnant on their own without seeing someone? Because we've got 15 million people have this.
Yeah. I remember when I used to kind of like coach people as well. One of the things I did was I would go through their diet. So I would ask them like, what are you eating? What are you, drinking? And then what I would do is make small adjustments. Like I'll give you an example. Macaroni and cheese. A lot of people don't know this, but if you look at the back of the box of a macaroni and cheese and you look at spiral mac and cheese versus elbow mac and cheese from the same craft, the calories are significantly less from the spiral. And I said to them, I go, here's a simple change where you reduce your calories by half. Same thing with, like I tell people, fat-free foods, completely horrible tasting. But what's interesting is if you mix fat-free with regular at a certain ratio, you reduce your calories again, and you're able to, again, lower those calories, which lowers the insulin resistance. And so there was a lot of things I used to do with that. What's your recommendation for people when it comes to diet? Like, how do you help them make those choices?
So there's stages, and everyone's individualized. So when someone goes through on the protocol with us, we do a lot of assessments as they go through. And we say an assessment, these are like 5-minute questionnaires that you fill out that helps you individualize it. So we do one that's it's not a diagnosis, but it's a risk assessment. How likely are you to have PCOS? We have a hair score. How bad is your hirsutism? We have a depression and anxiety score. We have a binge eating score. We have a sleep apnea score because so much of that is a factor. We have a mindset and goal one, because some people want to lose weight and some people want to get pregnant and some people want to get healthier, whatever your goals are. So we individualize it to a bit, but if you took sort of where 80% of people fall, we're going to start them off in that first 2 weeks. We're going to focus just on what they're eating, and we're going to skyrocket protein based on your weight. We have guidelines, but very high protein. We don't count calories. We don't count fat. You're not putting butter in your coffee. And we're going to get carbs down to nearly zero for the beginning. And then we're going to coach them and if they have a glucose monitor, we're going to see, are they actually eating it? So we get rid of processed foods, we plummet the insulin, and then they feel very full. The idea is never be hungry and never feel deprived. So you can go about your life, but reset your metabolism. A good one that you can put up. Do you have the little clip that says Rivera?
Yes. Give me.
So she'll tell you like what it's like to go through this.
You want me to start it?
Yeah, that'd be great.
It's something that's a lifestyle change that you need to make that's going to help your body get to where it needs to. After like a week or so, I was in such a routine. I was still eating the things I wanted to eat. I didn't feel like I was deprived. It was actually easier because I knew what I was doing. Once I got into it, it was very, very easy and very calming. Beforehand, I was very lethargic, very tired. And now after my workouts, I felt energized, ready to take on the day. I ovulated on my own, and I don't think that happened, for the past 2 years. So it's a huge shift. I didn't need to lose a significant amount of weight. And that's what I was told leaving my other clinic, like maybe lose 30, 40 pounds. When I came to you, it wasn't about weight loss. It was just about managing my hormones. And I thank God. I thank you guys every single day. If it wasn't for you, I wouldn't be here about to celebrate my son's first birthday. For people who are struggling with infertility and PCOS, don't give up. It's completely worth it. You can say, I wish I would have done this sooner. You're not alone. And as soon as I met with Dr. Palter, I knew it was the right decision.
So, I mean, that's like she says, like she went through a week. Like if you can, I tell people that like, it's so hard and I'm this, if you can get through the first week, when your blood sugar stabilizes, the cravings stop, the sleep gets better, the plummeting, the fatigue, the lethargy, and then the hunger goes away. And then you start eating less and you immediately get rid of the inflammation goes down, the insulin goes down, the male hormones start to go down. You feel better. You don't feel hungry. But we're not cutting calories. We're not pumping them on the treadmill for hours. We're just getting rid of the stuff that's driving the metabolic disease.
One of the viewers asked a question, Lynette. She said, do you work with people with food allergies?
Yeah, so we're not an allergy program, we're a metabolic reset. So the goal is to get your hormones fixed because you have metabolic infertility. Now, if you've got specific allergies and you need to be sensitized, that's not what we do. But a lot of people who think they have food allergies actually are reacting to these things. So there are people who will tell you, oh, you have a dairy insensitivity with PCOS. Oh, you have a gluten insensitivity. There's tons of carbs in those things. Gluten is often in all the processed breads, the refined white flours. And so if you go zero carb, high protein, you're not eating a lot of dairy except for hard cheeses. You're not eating gluten. You're not eating refined flours and sugars. And suddenly, these people who thought they had allergies, the inflammation goes away, their gums clear up. They say, I brush my teeth and it's clean in the morning. Their skin clears up, eczema goes away. People who they think they've got inflammatory bowel disease, or they have IBS, irritable bowel syndrome. Suddenly their bowel movements are normal. It's such an inflammatory disorder. So if we measure CRP, which is thought of as a marker of inflammation for heart disease, we see it elevated in the people with PCOS. And when we put them on these dietary changes, the lifestyle shift, before they lose weight, their insulin and their CRP are normalizing.
Yeah, and she does. It sounds like she has PCOS. So she has PCOS. She wants to do your program, but in this situation, she also has food allergies. I think she was wondering, like, can you work around that? With
you should be able to. Like, you should be able to, because when we're getting, whatever you're allergic to, there's not one thing that you have to eat on this program. We can work around whatever someone's particular, if you're looking to be desensitized to an allergy, but whatever you can't eat, there's a way you can do the program.
So this current person here, so I know this person. She's absolutely amazing. She's had some tough times in her fertility, but she loves your TikTok. So we told her she needs to come on and say hello to you, and she's a great person. We'd love to have her on. So hopefully she'll come on and say hello.
Yeah. So I mean, it's interesting. One of the things I would love the impact from people. It's so interesting. Like what stops people from taking action? It's like, because this is such a simple thing to do. And I think it's that, like, why do you not do something? Like, why do people want to do IVF and do all these complicated things without trying something like this? And I think it's because they've been burned so many times. They've been promised something and they tried 100 diets and it just sounds like the same thing again. And it's not there's a difference between a fad and something that's actually scientifically based. That's why that's why when we first put it out, we just said, you have money back guarantee. You do the program for a month. If you're not getting results, give you all your money back free.
Yeah. I mean, you hit the nail on the head. It's about guidance, and anyone can do it. It's just a question of guidance. That's really the big part. I think your program, the way you're doing it, is the right way. I mean, it inspires me. Like, maybe I need to do something similar because again, I can't physically do it with everyone. That's impossible. That's why most clinics can't put that type of focus.
We'd be happy to help your people. And I've gone through it. Like, I myself, I mean, I don't have ovaries or a uterus, but I have metabolism. So like, I've gone through every step of this program. I lost 40 pounds, got healthier. I've worn it. I'm not diabetic, never was, but I wear a glucose monitor, worn it for 5 years, and I use it for exercise and to make sure I know how the food affects me. I'm healthier now than I was when I was 20 years younger.
Yeah, we talked about this the other night. This would be a really good thing to talk about right now. Is we were talking about this idea that a lot of people, when they look at a hemoglobin A1C, they think, oh, look, I don't have diabetes. I'm not even close to it. Everything looks good. But you and I talked about how that there's a difference of having hyperinsulinemia, causing those levels to come down, but still having those spikes and those high insulin levels. I'd love to hear your view of how you treat that.
Yeah, put up the CGM graphic. So here's a woman who came to us for infertility with a normal A1C. And on the left here, that's her blood sugar. So she has a 24-hour glucose sensor. Her blood sugar is like, her baselines are like 120 to 130. And after meals, she goes up to 220. She's spiking after meals. She has a normal A1C, but she has diabetic range numbers here. Right. So this woman will be diabetic by the time she's 40 if she doesn't make a change. It's just that they're not drawing enough blood samples to pick it up. But I see that she's diabetic. So that's August 9th to September 7th. You then go 1 month later, September 15th to October 14th on the right. She shared this in the community on our app. Her blood sugar is like 90 to 110, flat line, normal. She reversed her diabetes that her doctors hadn't even diagnosed. And so the spikes of insulin and blood sugar, whenever you can take the picture down, like if you eat something and then come home and fall asleep and you're exhausted, that means your blood sugar shot up and plummeted. And that's a sign that you probably have insulin resistance and spikes of blood sugar. So, there are people who are, if you're very thin and metabolically healthy, you can deal with that. But people that have these genetic predispositions or are overweight, that is the diabetes of the ovary results.
What would you say to people? Let's say someone can't do your course, and there's people who won't be able to, or they're too afraid to do the course. What would be like the top 3 things you would just tell people with PCOS to at least start doing in their life?
So what I would do is I would start with the dietary portions. So eat protein, meat, fish, poultry, hard cheeses. Don't worry about fat and calories, and get rid of carbohydrates. Get them as low as you can. Get rid of sugar, grains, bread, and processed foods, and do that for 1 month and see how you feel. And so that's sort of like, we get into so much more nuance in individuals, but if you wanted like the one sentence, what you could do on your own. And the other thing I would say is be very careful. Companies want to sell you ovulation trackers. Like if your cycle's irregular, people with PCOS make LH hormone all the time. So if you're seeing that stick turning positive all the time, it's not accurate and it's not helping you. So if your cycle's irregular and you meet the criteria, facial hair, acne, irregular cycles, either do something like this on your own, or if 6 months have gone by and you're not getting somewhere, go see a specialist, get diagnosed, and use medications, because it's not going to just go away on its own. There's lifestyle resets, and then there's drugs.
I'd love to hear about any funny stories you have about PCOS. I have a couple. One of my favorite ones was when I was in residency, and I knew I wanted to go into fertility at that point already. I already knew a lot about PCOS. And there was a really funny story. Is one time I saw this patient, and she was put on birth control to get pregnant. That was really strange. I said, wait, why are you being put on birth control? And she said, well, because the doctor said last time when I got off my birth control, I got pregnant. So he wants me to go on for 3 months and then come off it so I might get pregnant again. And I thought, we were just talking about understanding the logic, like what's the real logic here is obviously the suppression and eventually gets her to ovulate. But the doctor didn't understand that, like, you could just use COVID or something.
Right. What they're doing is they're artificially suppressing the male hormones, and you have like a 1 or 2 month chance where you might ovulate. But not a very effective way of doing it. And women complain, online. I'll put through these things, say like, what's the most hurtful thing that a doctor said to you about your PCOS? And one is like, oh, just keep trying. Yeah. They know that's not gonna, like, if you're not getting a cycle, you could try 1,000 times, it's not gonna work. Or eat less, move more. But there's also just take a birth control pill. Now, we know that physiologically, the birth control pill suppresses a lot of the male hormones and gives you a cycle. But so many of these women want to understand the root cause of their problem, and they want to treat the root cause. So when a doctor just gives them a birth control, they feel like nobody's understanding or explaining to them what's wrong with their ovaries.
Yeah, I saw a patient just 2 weeks ago. For 1 year, her doctor's been giving her Provera to induce her period and told them to keep trying. And she's like, yeah, I'm getting a period every month. And I'm like, well, not exactly. You're getting a withdrawal bleed. And so, I think it's important for patients to understand clinically, if they got birth control and got pregnant and then never got pregnant again and had irregular cycles, you can almost guarantee you have some type of anovulation, something like that's going on.
Right. A lot of people think that the pill caused them to get PCOS. They call it online post-pill PCOS, but they were never, I say to them, well, why'd you go on the pill? Well, my cycles were really irregular when I was a teenager. It masks it. It'll hide all the symptoms. So
in a second here, we're going to be bringing Melissa on, but before we bring her on, she's the one that would say that she loved your videos. We'd love to hear from her. Like, how did your education help her? Like you said, the same with me. I do my podcast, not because I make money from it, not for a ego thing. I do it because I want people to have a different view. And I think you bring that to a lot of your TikToks. But before we jump on that, there was a question here, and we kind of touched on this earlier. And Brittany said this question: do you always have PCOS, or does it become an onset thing? And I think this goes back to that point where the one doctor said, oh, it's genetics. And you're like, Yeah, but that's not the whole story here. And I'd love for you if you want to answer this one.
I mean, think about it like diabetes. You can have a predisposition. So there are some people that are so sensitive, they have it from when they're first a teenager, no matter what they do. There's other people that have the predisposition to it. So they then need the second insult. They're at risk if they're extremely lean and very careful what they eat and metabolically perfectly healthy, it doesn't manifest themselves. And then but if they are in the bad environment, it comes out. So like someone who's at risk of diabetes but becomes overweight, you see the diabetes. And then there are other people that have a minimal risk that they have such a metabolic onslaught that you start to cause it. So it's like you have some degree of risk, and the more sensitive the environment, in some people isn't needed, in some people triggers it, and in others is the sledgehammer.
I find, and you probably find this as well, when people are overweight, it's almost like that PCOS is a little easier to resolve the symptoms with metabolic control. I find when people are very thin, it's a little bit harder. They have to be very, very stringent on their carbs and things like that. Do you find the same thing, that there's like it's almost harder in those situations because it's almost more severe?
It's because there's one, it's one lever that you don't have to pull. They don't have the weight portion and they're not as sensitive to it. So about 50% of the ones that are lean still have insulin resistance, but they have some of the worst metabolic portion of it. So, but they respond the same way. We had a woman who had done 6 IUIs and in 6 weeks on the dietary program ovulated and got pregnant on her own. But it can be difficult. It's like the same thing, like someone who's got diabetes and they're really overweight, you've got more to work with than one that's thin.
Yeah, and it's not about just the weight, as you said. It's more about that metabolic. The way I draw this little diagram, I should have drawn it for the show. I don't know why I didn't, but I show how when you have elevated insulin, how that actually causes testosterone levels go up, and then how the testosterone levels cause insulin resistance, which causes more insulin to go up. Insulin's a growth hormone, causes your adipose tissue to increase. Adipose tissue causes insulin resistance, causing more insulin. And it's just this vicious circle. Exactly. And that's what you have to break.
You can get in at any point. Some people it's triggered by the testosterone, some it's triggered by the fat tissue, some it's triggered by the insulin, but they all feed on each other.
There's one group I see, and I'm sure you've seen this too, where you almost see them and they have PCOS, but they have more of the metabolic syndrome. And they usually are having severe diminished ovarian reserve. These women are like almost near perimenopause. They usually have a very central obesity. They do have high androgen levels. And a lot of times they're told, oh, don't worry, you have PCOS, you'll be able to get pregnant in the future. And I see them, and I have to explain to them that, no, your AMH is really low. You have severe metabolic syndrome. How do you approach those a little bit different?
I don't know. I've seen where I can say the metabolic syndrome is causing it, but I do see this with aging. As people get older, the PCOS starts to get masked by diminished ovarian reserve, and then they have less follicles, and then they have less of the androgens. It starts to correct itself. But we try to treat them wherever they are. We try to treat the metabolic aspects first.
Correct. Well, I want to bring on Melissa, and like what I really want to know from her is I would love to know, what she got from your videos. I'm a little bit, I would say jealous in some ways. I mean, she's like one of my favorite patients. So now that I know she's watching your videos more than mine,
she's watching me.
I'm a little jealous now of you, Steven. So let's
she's
bring her
watching
on
me
here.
at night. She's watching me at night.
Well, let's move here to the front here. And Melissa, thanks for coming on.
Hi.
Thank you for watching.
I'd love to hear what did you find when you were watching these videos and stuff, like other than just entertaining? I mean, what did you learn from them?
I mean, I can't pinpoint like one thing right now because you put me on the spot, of course. But what I will say is that I love the medical mystery videos that you do, where like you have a patient and you say like, oh, okay, there's this, and this, and then we have to like guess kind of like what it was that caused their issue. So I love those videos. I do TikTok as well. I've been kind of, I guess, sharing my journey because I think it's super important, especially for people who are in my situation who IVF may not work. So I think it's kind of always nice to have a little bit of both, the success stories and then the non-successful stories. But I absolutely love all your videos. And I'm
Thank
so
you.
when I hopped on here and I, came up on my feed, I was like, oh, I love him. There's my husband.
It's it's funny. The medical mysteries, they're 5 seconds long. And every one of them is something that I've seen so many times where this happened. What's the cause? And then I'll get like hate comments of people, why don't you just give us the answer? And then I'll say, because there's going to be 1,000 comments and I'm going to answer them all. And you're going to learn 100 times more about how to think about your disease than if I just gave you the answer. And at the end, you say, now bring this back to your doctor. And it's just, 70 million people.
Yeah, they're great videos. But on the topic of the whole PCOS and insulin resistance and all that, I was never actually diagnosed with PCOS. I guess I don't have like the typical symptoms, but they do say that I have signs of it because I do have the insulin resistance. I was borderline diabetic. I got a got it probably a couple years ago, and before I even started taking any medication, I put that bad boy on and just saw like what it started doing. And I'll never forget, we were driving home from California. We were driving back to Arizona. And I always used to get like a coffee and like one of those breakfast sandwiches from Starbucks. And I am not even kidding you. I almost had a heart attack when I saw what my glucose did. I mean, it shot up to like past 260, I think. It was crazy. And so I think it was super eye-opening to have the Dexcom, and I feel like more people should have access to those because it is really useful for those of us who are borderline diabetic and on the way there, just to kind of get that interest, the more information, I guess, to see like what our bodies are actually doing, when you eat certain things. So,
When you say you
um,
had some of the features, I think this is super important because I think of it as it's not I have PCOS or not. The reason why it's called a syndrome is it's not one disease. It's a whole bunch of different things that come together. So high male hormones, inflammation, insulin resistance. You can have more or less of one or the other one of them. So like when you say, oh, she's pre-diabetic, she's not. That's mild diabetes. So what
yeah,
you do is what you saw was you have the insulin resistant component. That's not good for any part of your health.
yeah,
So by you taking control and getting the feedback loop, I'm not going to eat that. It does this, and then you get healthier. That
yeah,
works for everyone. And I hate the way with PCOS, it's putting the woman in the box. Do you have it or not? I work much more on what features do you have that are not healthy, and can we correct those as opposed to do you fit in the yes or no? How do we get you healthy?
yeah. So since all that, I was put on metformin. That didn't really do too much. Then they put me on Manjaro, and that has done fantastic. My blood sugar absolutely loves it, and I've been successful losing weight. But there lies the problem. Like, I don't want to have to be on that for the rest of my life. And um, I mean, it's ultimately still comes down to me being able to control my blood sugar better and eating the right things. And it's tough. I mean, I was gluten free for almost 2 years when we were doing fertility treatments, trying to lower my inflammation and all these things. And um, it was very tough. It's not an easy task by
Well,
any means.
it 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 can be harder or easier. It's sort of something you always have to do. I do it myself. But one of the diabetes reversal partners that I work with, who when I was developing the program, we shared a lot of ideas. He takes people who are diabetic and have huge, like hundreds of pounds of weight to lose without a GLP-1, overall 12% body weight loss at up to 5 years retention. That's the same results as a GLP-1 with lifestyle 100% only.
Yeah.
But it's doing what we do, where you've got a program, a coach, and a monitor, and you're getting the feedback. So you can do it with a drug for the rest of your life, or you can have a community that kind of someone who guides you And then after a few months, you know the tools and you have the power yourself. You
Yeah.
can, that's how you get off a GLP-1 is you've got to so when you think of it, if you eat carbs, that's slamming down on the gas to make your body make insulin and make your blood sugar go up. So you can slam on the brakes with a drug, or you just take your foot off the gas. Can that be hard? Sure. If I go out to a meal and we had a holiday party and there was fried calamari and chocolate cake, I was like, if I eat that, I know what's going to happen, but I don't want to be on a GLP-1.
Yeah. No, I agree. It's definitely in our control, right?
You've done great. You've done everything
we
great. You've done everything great, but you have tools. The way I like to look at the GLP-1 is if you need to reset, it'll let you do it fast and you'll learn to eat differently. But just like gastric bypass, if you don't change your habits, that surgery and that drug will not work for the rest of your life. So it's giving you the tools to get started. You can then extrapolate from what you've done and make a lifelong way to not be on it.
Yeah, definitely. The portion control, I say, is probably the biggest impact. And also, I realize I can't eat certain things. And I do like that because I feel like it's going to kind of brainwash me once I do get off of this to kind of eat better. But
One of the
one thing I did notice was when I wasn't on any medication, the order in which you eat your foods is super important. And then if you do have the carbs, I learned that if I walked after my meal, my blood sugar spike was way less, if at all, just from
Right.
walking. And I think that's something super important for people to know, because some people don't understand that. They don't know. Just a simple walk after a meal.
So three or
will do
four
wonders.
hacks I can give you that you've already got. One of them is when you think you're hungry, for me and many people, 75% of the time you're not hungry, you're stressed or bored. In Japanese, there's a word like my tongue is lonely or my mouth is lonely, or you're under stress. So you think you're hungry. If you drink 2 or 3 glasses of fluid and say, I've got to wait 15 minutes before I snack, very often you don't want the snack. If you eat fiber and protein before you eat the carbs, your blood sugar will spike less and you'll want less of them. If you walk within an hour, like they do in Italy, after every meal, you go for a walk, your blood sugar is less. So those are things you can do. Just the order in which you eat your food and what you do with exercise and paying attention to what does hunger mean, you can drastically improve yourself.
That's funny that you said the water one because my husband literally lives by that. He's like, "Oh, I'm not hungry. I'm just probably thirsty." And he'll drink a couple like glasses of water and then he's good. So he
Yeah.
totally preaches that.
Water's a good one. That it does help with satiety and stuff. In all fairness, I kind of make it harder on them too because I'm always trying to get them to go to Dave's Hot Chicken with me. So I gotta stop trying to tempt them with that.
Still waiting on that.
Yeah.
I know.
Do you hear Mike?
Yeah, we're gonna go. We're doing the spicy one. So
I can't eat that anymore. It hurts my stomach. But you
Melissa,
can go with Mike.
yeah, I will also see you there. But Melissa, thanks so much. I really appreciate coming on and
Thanks for coming on.
I'm jealous, but I understand. I watch his videos too, so I get it.
I just went to.
You don't make TikToks, Dr. Amel, so
I know I stopped doing it because he was doing it so well. There was no reason for me to do it. So I put my focus on the podcast now.
It was weird. I got to the point where patients come to see me from out of town, and like when they do their consults, they want to take selfies. And then and I went to this awards banquet for fertility, and like there were doctors like, "Can I just take a picture and do an Instagram with you?" And I said, "This is so weird."
That's too funny. Well, thanks for having me, and thank you
Keep
for
up
your
the good work.
TikToks.
Yeah,
Keep up the
it
good work.
Melissa.
Thanks. Talk to you guys later.
Bye. I know we're getting near the end here. And there was a couple questions that came in. I just wanted to kind of put up. I thought they were really good questions. And I think it would be great to have you answer these too. So we're just kind of a bunch of questions real fast and then we'll end here. But so this is one that someone came in from Star Wars Tour 1969. Can celiac disease create infertility?
So what's your take on it?
So I don't think it can create infertility, but I think the thing that could definitely happen is that, anything that creates inflammation, anything that creates an environment that could be hostile can always affect it. I mean, we see endometriosis, a tiny bit in the body reacting to it can cause egg quality the embryo quality to drop and stuff like that. So I do believe there is a pathway for it. I think it's not just having celiac disease, but I think you mentioned it earlier about when people aren't, when they're low in their gluten, it helped them sometimes too. And I think there is a pathway. I don't know if it's going to be completely direct where you have celiac disease, you're going to have infertility, because I know people who have gluten disease and they end up having fertility, but there is a path, and that's why every person is different. This is where we go back to, Stephen, you and I talk about that. You can't just lump everyone together. You have to look and go, well, what's their situation? Here's what's going on. What's their inflammation? And it could be more than one thing, but yeah, I do think there is a pathway for that.
I think I agree 100%. I think it's a contributing factor, and how much it contributes. Like, there's tons of people with celiac and most aren't infertile, but if you have it and you have inflammation, you have infertility, it's a component that you can modify.
Exactly. Another one to jump on here this is from Arden Fern. She said, is insulin resistance something tested for before fertility treatments, or something that needs to have been diagnosed from a PCP beforehand? This kind of reminds me of, that comment, what's it? I always make a joke about PCOS. You know it when you see it. It's kind of like porn. You just know it when you see it. You don't have to define it. I don't think a lot of us test for it, and I'm assuming you're probably similar. Like, I can look at someone and know there are signs of insulin resistance. There's acanthosis nigrans. There's central obesity, things like that. But in general, what would you say to her?
Yeah. So most fertility centers don't test for it. We do, and people in the protocol, in the PCOS to pregnancy protocol, we test for it because we want to see how much it factors, and we want to see it get better. You can know. So Mark talked about acanthosis nigricans. That's that black velvety skin on the back of your neck, skin folds, or in the groin. Huge sign of insulin resistance. Skin tags, a huge sign of insulin resistance. In a woman, if your neck is over, I think it's 13.5 inches, your waist over 34.5 inches, very predictive of insulin resistance. If your waist to hip ratio is greater than 0.5, very high marker of insulin resistance. So those are benchmarks you can do on your own. But of people with PCOS, 75% of insulin resistance. If you're thin PCOS, 50% of insulin resistance. So you can get a good idea of this on your own. I think everyone should have, anyone who's overweight or has infertility or has irregular cycles should have a hemoglobin A1C level, a fasting blood sugar, and a fasting insulin. And that will give you that. And these body measurements will give you 90% of the diagnosis.
Well, for anyone who wants to, see some of Dr. Palter's videos, or even just anything stuff, you can go to his tag at Stephen Palter MD. It's all over like Facebook, Instagram, TikTok. It's really a delight to watch. I watch his videos all the time and always harden them. So definitely go on and check it out. I really appreciate you coming on, and I hope maybe you can come on again in the future. We can do a different topic. I know you and I are going to be doing some podcasts, some about polygenetics, which is kind of controversial right now, and again about PCOS. And so I think people can look forward to those as well. But again, thank you so much for being on. I know, Dr. Salem, you came on late, a little bit later. You were stuck in traffic, but you got to watch him too. He's fantastic as well.
I will definitely get to watching some of these TikToks. That's for sure. So yeah, no, thank you so much, Dr. Palter. It's great seeing you as always. And
I appreciate you. Appreciate you making the effort to get here, or even being stuck on the way over. Mark, you're a kindred soul. I love talking to you. We learn together, and I appreciate the opportunity to be here. It's, you are in it to help patients. It's so clear. Your heart is in this to help people, and I just love being around it, and that's why we're here.
Well, I really recommend people checking out his program. It's up on the page here. And again, he's giving you 20% off. That's even better. So check it out.
Cheaper than a consult.
Yeah. Thanks so much.
All right. Great. Have a great night, guys.
Happy holidays, everyone.
Got the knowledge, the power to grow. Sperm meets egg, let the healing flow. fertile grounds we explore. Life's a journey, so much in store. Got the knowledge to how to grow. Sperm meets egg, let the healing flow. Step in, let's talk about the facts. Women's health, let's watch how it cracks. Cycles turning, it's more than just chance. In this moment, we're taking a stance. Voices rising, we're breaking the mold. Deep conversations, we're watching them fold. From the roots to the stars, is one and the same. Empowered together, we're winning this game.